Before we go to mechanical ventilation, let me show you ARDS first so that the therapy makes more sense. What is ARDS? This is a progressive form of respiratory failure. Since it's also a respiratory failure, does it still have an ABG of less than PaO2 less than 60, PaCO2 over 50, pH less than 7.35, and oxygen saturation less than 90? Yes, it meets all the criteria of respiratory failure. On top of that, however, the patient now has a refractory hypoxemia. What does refractory mean? Unresponsive. So unlike respiratory failure, wherein the patient improves when you give them oxygen via non-invasive or non-invasive means, these patients do not, meaning no matter how much oxygen you give them, they do not improve. Why? Okay, so let's look at the mechanism. How did this happen? So the causes are the following. Chart 19-20, aspiration, COVID, pneumonia, drug ingestion, all the way here. Now, are these minor or major conditions? These are major, serious, life-threatening conditions. So if you remember in sepsis, we actually talked about capillary leak syndrome, remember? Okay, so the patient has injury, acute lung injury. So this is one form of acute lung injury. So the patient suffers acute lung injury from many of these. So sepsis can be anything. It could be from sepsis from pneumonia, or it could be sepsis from pancreatitis or peritonitis, meaning very far from the lungs. But still, it led to sepsis, and we know how the body reacts to sepsis. We go into capillary leak syndrome, correct? Or increased capillary membrane permeability. So this causes fluids to leak out of every capillary. Now, in this particular chapter, this will focus only on the capillary leak in the pulmonary system. So there's also pulmonary leak everywhere. Same thing as what happened in DIC, right? In DIC, this happened also. So here, where this section of the textbook will only talk about what happens in the lungs. So because the 100 million alveoli we have are wrapped in a capillary network. So imagine if each of those capillary networks surrounding the 100 million alveoli leak fluid. So where will this fluid go? Since they're wrapping. So this is, let's say, imagine this is an alveolus. This is one air sac. There are 100 million of these. Each one is wrapped by a capillary network. And if each of those capillary networks leak water, where will that water go? Inside the alveoli. So each one of your 100 million alveoli now contains water. So how can gas exchange occur if there's water in the lungs? It can. Okay, so does it explain why there is refractory hypoxemia? Okay, so that's the explanation. No matter how much oxygen you give, gas exchange is impossible because of the water in there. So the only way to do this is to put the patient on a mechanical ventilator. We have to ventilate the patient under positive pressure. So all ARDS patients will be intubated. And how this works is, so let's say this is the alveolus, and then there's a capillary around it, yeah? So when the ventilator pushes the air under high pressure, it will push all this water back into the bloodstream. However, when the vent stops giving a breath, where will the water go? Go right back in there. However, for that moment there of 1 to 2 seconds, was gas exchange made possible? Yes. Okay. So that's the only way we can keep ARDS patients alive. Now, how long will this condition last? We don't know. Just like were we able to predict when, how long the capillary leak syndrome lasted? No. So same thing. So the ARDS, since it's directly linked to acute lung injury, which leads to the capillary leak syndrome, we don't know how long this condition will last. Okay, so this is again an over-exaggerated response by the body to one or more of these serious conditions. Any questions so far? All right. So we know the patient is in respiratory failure. We know there is refractory hypoxemia. Now on X-ray, there will be pulmonary edema with infiltrates on both one or both lungs. Now, lung tissue on X-ray, what color is it? You've seen pictures or maybe you've seen your own X-ray film. So what does the lung tissue look if it's filled with air? It's black. It's black. The whites that appear are the ribs and your vertebrae and your heart, because why? They are solid, right? The heart isn't solid, but it's filled with water. So, blood. So therefore it will appear white. However, since the lungs are filled with air, they will appear black because air is invisible, correct? However, here, because now both lungs are filled with water, how will the lungs look on X-ray? White. Okay, so this is what we call a white-out appearance, or they also call it ground glass. Have you ever seen ground glass? Like no matter what color the glass is, if you pound it into a powder, what is the color of that glass? Whether that glass was clear or blue, green, you pound it into a powder, what color is it now? It's white. So same thing. So the term can be either white out or ground glass appearance. Okay, that's the description of the chest X-ray of a patient with ARDS. Now, let's say the patient on the other bed has heart failure. Remember in left side heart failure, there was also pulmonary edema, correct? This also has pulmonary edema. So if you take chest X-rays of both patients and put them side by side up on the screen, how will they look? Will they look different? Exactly the same. So how can you tell? Let's say this patient is in ARDS. You took X-rays, but this other patient has also pulmonary edema, but from heart failure. So how do you tell them apart, therefore? How do you know? Oh, this patient has pulmonary edema from heart failure. This other one has pulmonary edema from ARDS. So how can you tell them apart? What labs will distinguish? What lab was elevated in a patient with heart failure? No, troponin was in an MI. BNP, remember? Okay, so what will be the BNP in the patient with heart failure? High. What would be the BNP in the patient with ARDS? Normal or low. Are we clear? So that's how you tell them apart. Plus, let's say this patient has a pulmonary artery catheter. What will the pressures be inside? So you have a pulmonary artery catheter in the pulmonary artery, obviously. So what will the pressures record in the patient with heart failure? What will the pressures be inside the heart if it's heart failure? High. What will be the pressure recorded in a patient with ARDS? Normal or low. Make sense? Okay. You'll remember that on the test, yeah? Okay, we'll see. We'll see next week. So any question about the pathophysiology? So again, it's a form of acute lung injury caused by these here. Chart 19-20 all lead to acute lung injury. Then that triggers the capillary leak syndrome or the increased capillary membrane permeability, leading to ARDS. Treatment. So here's the pathophysiology. So it talks about acute lung injury. Manifestations again, patients the same as any patient with pulmonary edema. So crackles in the lungs, hypoxemia, hypoxia, respiratory distress, refractory hypoxemia, meaning you put them on oxygen, the reading remains below 90, yeah, below 90%. They don't respond, still symptomatic. And because again, the patient this is a form of respiratory failure. Look at the ABG, same thing. Okay. So PaO2 less than 60, PaCO2 over 50. And then now you have um, this is what we call an FiO2 to PaO2 ratio of so look at this. So let's say look at the in severe, okay, just to give you an idea. What does PaO2 FiO2 ratio mean? This means that you divide PaO2 by your FiO2. So let's say your PaO2 is 60 and then the FiO2 was also 60. What's your answer? Which is less than 100. Okay, make sense? Okay. So that's what we call PaO2 FiO2 ratio. So you divide the patient's PaO2 by the concentration of the oxygen that you were giving the patient when that ABG was drawn. So the lungs are wet, so are they compliant? No, a lung is supposed to be dry, yeah, filled with air. Now it's wet, so it's very non-compliant, it's very stiff. So how much pressure are we talking about here as far as the ventilator is concerned? So maybe. So if the let's say the the ventilator, right? So it will push the air. Now, if the lung is wet, how much pressure do we need to deliver that tidal volume? Tidal volume is the amount of air delivered by the ventilator with each breath. So how much pressure do we need to deliver that breath? High pressure is needed. But when you actually break through the water, how much volume are you able to put in it? Low. So that's the problem with any change in compliance. So if the lung compliance drops, which means it's stiff because it's filled with water, you need higher pressure, but the volume is very low. Whereas if it do the reverse, in a very compliant dry lung, how much pressure do you need to deliver a little bit, but the volume is very high. Okay, so that's the relationship. So when you think about the ventilator later, when you see the pressure and the volume, it will tell you about the patient's lung compliance. Okay, so it will tell you, the ventilator settings will tell you how stiff or how unstiff is this patient's lung. Okay, so that's always talking about the compliance. It gives you an idea about how bad or how good is this patient lung based on the pressure and volume settings on the ventilator. Any question on ARDS? Okay, that's it because we already talked about the diagnostic findings. So we said the BNP will be no in ARDS. Okay, low. So it tells you here, right? So there the BNP is normal or low. Okay, in ARDS, whereas it'll be elevated, of course, in heart failure. And also, if you had the pulmonary artery, okay, if you had this, then of course it'll be elevated in heart failure, but then normal or low in ARDS. And as mentioned here, so medical management is just like respiratory failure. We give the patient oxygen. However, because this is now involving a wet lung, is a non-invasive oxygen delivery possible? No, it has to be mechanical ventilation. Right? It has to be invasive. All right, let's go to other problems here is we have to, we'll discuss PEEP when we get to the ventilator settings. Hypotension occurs in ARDS. Why? The lungs are wet. So therefore, what happens to the cardiac workload? No, how much effort does the heart have to do to pump blood? A lot, right? So the cardiac workload increases, so therefore what happens to cardiac output? Decreases. So that's how it leads to hypotension. Okay. Let's finish the drug therapy. So can these patients benefit from steroids? Latest evidence says not really. Okay. Plus, because of what happened again? How did this water end up in the lungs? Okay, therefore, because remember there is hypotension here, correct? So does the patient need fluids? Well, no. Just answer that question. Okay, so the patient has systemic hypotension. So do they need fluids? Just that. Don't consider anything else. Does the patient need fluids? Yes, they do, because this is not a heart failure patient. Yeah, this is an ARDS patient. Yes, technically they need fluids. However, when you do give fluids, because of the capillary leak syndrome, where will each drop of your IV fluids go? It will end up in the lungs. Okay, so now there's a catch-22 here. So your patient needs fluids, but then when you give fluids, it will end up here. So do we give fluids or not? Very gently. Okay, so the answer will be cautious fluid administration. Okay, so you give maybe 50 ml per hour just to maintain, okay, enough blood volume to support perfusion, to maintain what's the mean arterial pressure goal again? 65, right? So as long as we reach a 65 mean arterial pressure, we're happy with that. Okay, so just gentle hydration, not to, overhydrate the patient because of the ARDS, right? And the other medications mentioned here are related to the intubation, because we have to sedate the patient and to paralyze the patient. Yeah. And we assume whenever we sedate the patient, we assume there is pain. So we give them opioids as well. Don't forget to feed the patient. So we do insert NG tubes. This is part of the protocol already, meaning we have a checklist, okay, so that we don't forget, because sometimes we forget because we're so focused on saving the patient's life, the respiratory and the pulmonary support, that we forget the nutrition part. Okay, so so if the doctors forget, just remind them, hey, about a feeding tube. When they say, okay, okay, yeah, let's insert one, okay, and then we'll start feeding. Because what is these patients' metabolic requirements? Very high. These patients can require up to 5,000 kilocalories a day, like somebody training for a fight. Okay, when Mayweather or Pacquiao trains for a fight, they consume an average of 5,000 kilocalories a day, okay, when they're training. So this is how much, and this patient's just laying down, okay, not doing anything. They're sedated, but yet they have a very high calorie requirement because they're so sick. Okay, so very sick. The patient is in a hypermetabolic state. Okay, let's go now to the mechanical ventilation, because we have to intubate these patients and then put them on a ventilator. Let's go back to page 563. Oh, sorry, yeah, 560.
So can they receive diuretics?
Remember, there is already a low cardiac output, so no. Plus, is the diuretic really gonna help? It will just make the blood pressure lower, because it's not really a fluid overload problem. It's a leaking capillary problem. That's the problem. Hey, the patient did not have fluid overload. It's just because the capillaries can't hold on to the water. Hey, they leak. they're leaking proteins, they're leaking large molecules. That's why the patient is in pulmonary edema. So the diuretics is actually contraindicated. No, not appropriate in this scenario. So here's mechanical ventilation. Now, the mechanical ventilator really is a computerized bag valve mask, if you think about it. So if, let's say, we run out of ventilators, what can we do? How do we keep a patient alive? Manually bag the patient. Are we clear? So if all goes bad, let's say your ventilator has a problem. So let's say Tenzin says, I can't fix this damn ventilator. Okay, I don't know what's wrong with it. So should she keep the patient on that vent, which is not working? No, she'll have to disconnect and manually bag the patient. Okay. So here we are. So which is more efficient? Manually bagging or letting a machine do it? Okay, so now we have a machine doing it. But again, we don't have this. We can actually pay somebody to manually bag the patient. Okay. So what should you have at the bedside at all times when the patient is on a vent? The bag valve mask. Okay. So that's the most important equipment there, if you ask me. All right. So mechanical ventilator nowadays is positive pressure. We do have negative pressure ventilators in museums. Okay. Or maybe in some polio victims that are still alive. But generally they're relics. Okay, they cost a lot because they belong in museums, right? Because now we have positive pressure ventilators only. Okay, so who is intubated? So we talked about respiratory failure, ARDS patients, and then surgery patients. Yeah. So if you go into major surgery, you have to you receive general anesthesia. Then of course you need a ventilator. Right. So here are the indications. That's very good. Select all and apply question again. Okay. All right, we'll keep this simple. We'll only talk about positive pressure ventilators. So the negative pressure ventilators, you hear them, iron lungs. There was a news I read 2 weeks ago that he was a famous patient apparently. I don't know for what, but he was a polio patient and he was an iron lung for most of his life, and he died recently. Okay, so he was on the news because again, these cases are very rare now. Okay. So here are the indicators again. So let's go to most of our ventilators are either pressure cycled or volume cycled ventilators. Now, regardless of what type of ventilator you have, the settings are the same. Let's go to the settings first. By the way, please know that BiPAP, CPAP are positive pressure ventilators, but they're non-invasive. Okay, non-invasive. So you only put a mask. Hey, we don't have an artificial airway for CPAP and BiPAP machines. High flow is not invasive at all. It's a nasal cannula.
High flow, CPAP and.
Well, the delivery. You have a nasal cannula for high flow nasal cannula. Okay, let's go now to the, before I go to the mode, let's go to the settings first. We will only talk about 3 modes, just enough to get us through the NCLEX, because these 3 modes are the most commonly seen. Okay, so the other modes available are used in the ICU, and since you're not expected to work in the ICU for the NCLEX, so that we don't need to know, because there are over a dozen modes. Okay, so we'll only talk about the 3 most commonly used. And these 3 modes are in nursing homes, in med-surg units. Okay, so you'll see them a lot. Okay, let's go to the settings first. Chart 19-5. So the ventilator again is a computerized bag valve mask. So since it's a computer, you have to tell it what to do. Your computer has settings, yeah? So same thing here. So you have to tell the ventilator what to do. First setting is the tidal volume. Tidal volume is how much air do you want the vent to deliver with each breath. There are two methods to do this. Either you measure it using a height, but most hospitals measure or calculate the tidal volume using the weight. So it's 6 to 10 mLs per kilogram or 4 to 8 ml per kilogram for ARDS. Why is it less for ARDS? Remember when we talked about compliance earlier? How much pressure do you require to deliver tidal volume? But how much volume are you able to deliver? Less. Okay, so that's why it's less volume in ARDS. So let's say it's a non-ARDS patient. So it's anywhere between 6 to 10. Most hospitals use 8. Okay, so 8 mLs per kilogram. So the average, therefore, tidal volume is around 350 or 400 ml. Okay. So on the machine, the symbol for tidal volume is capital V and a small letter T. Okay, so that's tidal volume. Next is the FiO2. As I mentioned earlier, FiO2 must be kept at the lowest possible percentage in order to avoid oxygen toxicity. Because remember, the patient will be on this for several days. So we don't want to deliver too much oxygen. Because how much oxygen are we used to? 21% only. So if whenever you increase that, it must be the lowest possible in order to meet your goals. Our goal is, let's say, 92% or 95, just the amount necessary, okay? Enough FiO2 to meet that goal. Inspiratory pressure is not a setting. This is the patient's response, meaning inspiratory pressure depends on the patient's lung compliance. Okay, so this is the maximum pressure you can deliver at the peak of inspiration without rupturing lung tissue. Okay. Okay, set the mode. We'll talk about mode later. Now, this is not really significant because we always put this around 1.5. I haven't seen the size settings really different from any patient. It's like a standard 1.5. Okay. Sensitivity. Now, the sensitivity is also called the trigger. Now, the vent has to know, when do I deliver a breath? Okay, so you have to tell the vent when to deliver a breath. So the sensitivity, therefore, is a negative pressure, because when we breathe, no problem if the mode is control. Control mode means the ventilator is in charge 100%. It gives a breath, doesn't care about the patient. Okay, that's a control mode. Now, we only see a control mode in the OR, because imagine, Miss Simon, if let's say you're conscious right now, yeah? I put a tube endotracheal tube in your throat and set the ventilator to control, which means it's 100% in charge. You have no say in when you breathe. You want to breathe, but you can't because the vent won't give it to you. The vent will say, I'll give you a breath when I'm damn good and ready to give it to you. Is that comfortable for a conscious patient? No. So the only way a control mode will work is we have to sedate and paralyze the patient. Okay? So you only see that in the OR. Okay? So let's say Garrison is undergoing heart surgery. So he'll be on a general anesthetic, yeah? So he'll be on a vent. So he has no say. He's paralyzed. He has no control over his breathing. The ventilator will keep him alive. He'll get a set number of breaths, set tidal volume each time. That's it. He has no say about taking any breaths. Does that make sense? Okay. So here, in any other mode wherein the patient is allowed to breathe on their own, we have to put a sensitivity trigger. So if the patient breathes, what happens to the pressure when our diaphragm contracts downwards like that? what happens to the pressure? Is it positive or negative? Negative. Okay, so if the pressure is set at, let's say, negative 1.5 centimeters of water, it will be sensed by the ventilator. So the ventilator senses the negative pressure like that. So therefore, what will the vent do? Oh, you're trying to get a breath. Here you go. Okay, does that make sense? Okay, so that's a trigger. All right. You'll understand this setting later when we get to the modes. Okay, but this is what a trigger means, meaning this tells the ventilator when to give a breath. Minute volume, this is simply, how much was the total. So how to do this is you simply multiply the number of breaths per minute times the tidal volume equals minute ventilation. Make sense? Makes sense, right? Meaning, yeah, total how many breaths was given for this minute and how much was each tidal volume. That's your minute ventilation. Okay, so we adjust the setting depending again on the patient's oxygenation needs. So if the current settings are meeting the goal and the ABGs are normal, then leave it. If not, then we need to make changes. Right. So there is a chance wherein there's a possibility that the patient will fight with the ventilator, meaning there's asynchrony between the vent and the patient. Best thing to do is assess the problem. Okay, so why is this patient uncomfortable? Why is this patient fighting the vent? Maybe it's your sedative. Okay, or maybe your settings. Okay, maybe your settings are not appropriate. It's making the patient uncomfortable. Okay, so until you figure it out though, disconnect the patient from the vent and then manually bag them while you wait for the respiratory therapist or the doctor to come. Okay, just to keep the patient comfortable. I mean, you can't leave that patient like that. Yeah. So you just disconnect and then manually bag the patient. Any questions so far on the settings? Very good. Let's go to the mode. Like I said, we'll only talk about 3 modes. First mode is assist control. Assist control, also called continuous mandatory volume ventilation. So AC or CMV. AC is assist control and CMV, same mode, okay, different names. Okay, so what is this? So I described to you the control mode. What is control mode again? So control mode delivers a set number of breaths per minute at an exact amount of tidal volume, minute after minute. Okay, so let's say the tidal volume is 400 ml, and then you set the ventilator rate or frequency to be 12. Patient will get a breath every how many seconds? So if the rate is 12 per minute, so the vent therefore will give the breath every how many seconds? 60 divided by 12? 5. So every 5 seconds on the dot, every 5 seconds, the vent will give them 400 ml. Stop, wait the patient to exhale. 5 seconds later, another breath. Okay, 12 times every minute. That's control mode. In AC, that's why it's called AC, because it assists the patient while maintaining a sense of control. How does this work? So there are 2 things preset here. There's a preset tidal volume and a preset rate. Again, 2 things preset. Tidal volume and a preset number of breaths. Now, for this to work, is the patient breathing? Because it's assist control. So, yes, actually. So most patients, most ARDS patients or respiratory failure patients are on AC. Okay, I should say really mild ARDS. Okay, so mild ARDS or respiratory failure patients start on assist control. Okay, so are they good or bad? No, their health. Are they good or bad patients? They're bad. They're pretty bad. So we put them on assist control. Okay, almost everybody starts on AC. So what does this do? It has a preset tidal volume right here, preset tidal volume, and a preset rate. Okay, so let's say the preset tidal volume is 400 and the preset rate is, let's say, 10. Okay, so if it's 10, every how many minutes will the ventilator give a breath?
Sorry.
Every how many seconds? Sorry. 60 divided by 10.
Oh.
Okay, every 6 seconds, the patient will get a breath from the ventilator. How much will the ventilator get? How much tidal volume? 400. Okay, right. So the settings, let's say, is tidal volume is 400 and the rate is 10. Question so far? So every 6 seconds, the vent will give a breath. Okay, so let's look at the next statement. However, if the patient initiates a breath between the machine's breaths, the ventilator delivers the preset tidal volume or pressure. So this is what we call an assisted breath. That's why this mode is called assist control. So is the patient allowed to take a spontaneous breath here? Yes, the patient can breathe. However, when the patient initiates a breath, so this is where that trigger, that sensitivity comes in. So let's say now the patient got a breath from the ventilator. They got 400. Before the 6 seconds is up, the patient initiates a breath. Okay, they want, the ventilator senses that, oh, you want a breath. Here you go. The patient will receive 400 ml. The patient cannot control the tidal volume because if they initiate a breath, the vent will give them the preset tidal volume. You understand? So what can the patient control therefore? Because it's assist control. What exactly can the patient control? The number of breaths per minute, meaning is the patient restricted to 10 per minute?
No.
No, because the patient can initiate a breath. Okay, so therefore, can the patient therefore increase the total breaths per minute?
Okay.
Yes, the patient is allowed however many you want. Okay, so yeah, every time you want one, okay, here you go. Okay, the patient can't control the tidal volume though. They can only control how many breaths total they get per minute. Any questions so far? Now, the problem here in this setting is, what if the patient takes more breaths, more spontaneous breaths? What will be the total breaths per minute? Let's say they take 14 out of their own, and the vent will give 10, because no matter what happens, the vent, you programmed it to give 10. So it will give 10, regardless of what the patient does, because you told the vent to do so, right? You put them on AC mode, put the setting there, okay, give 10, 400 each time. So of course, the vent will follow what you told it to do. Okay, every 6 seconds on the dot, I'll give one. But if the patient wants one in between, okay, here you go. Okay, they still get the 400. So what will happen to the total breaths per minute if the patient now breathes more and more spontaneous breaths? What do we call that condition? Hyper. The patient will hyperventilate. So what will your ABG result be? Respiratory alkalosis. Is that bad? Yes. Can we keep the patient on the same mode?
No.
No, because are they getting better or worse? No. I mean, why are they taking more breaths?
Oh, because they're getting better.
They're getting better. Okay, they're getting stronger. They're taking more and more breaths. So can we maybe try decreasing the frequency on the AC? Yes, you tell the doctor, okay, so you tell the doctor your findings, give them the ABG result. Hey, I got respiratory alkalosis. Okay, this is the total number of breaths per minute, because they will record. They check the vent. Okay, I got 24 to 32 per minute. What do you want to do? Okay, they'll say, okay, let's try decreasing the preset rate. Okay, keep the tidal volume at 400, change the rate to say maybe 8, or 6. Okay, let's try. So that could be an option. However, if the patient now continues with the same and lung sounds are good. So it's not appropriate here anymore. So let's go to the next mode. So now we will use SIMV. We'll skip the intermittent mandatory because this is really for it's not very common. So most common are AC or CMV and then SIMV. Okay, and then the PSV, which is the third, the next one, PSV. So we'll only do AC or CMV, SIMV, and PSV. So what is SIMV? So this is designed for a better patient. So the patient that was in AC or CMV, but then now got better, so we'll put them on SIMV. So what is SIMV? It's synchronized intermittent mandatory ventilation. It's still a volume mode, so just like AC, it has a preset tidal volume, it has a preset rate. Again, it's still a volume mode, so it has a preset tidal volume, it has a preset rate. Because remember, the patient came from the AC mode, and now we switch them to SIMV because why? They were getting better. They were taking more and more spontaneous breaths. So since this has a preset tidal volume, preset rate, what do you think the preset rate will be if the patient is taking more breaths here? Give me a number. Kurt. Around 6 or 8. Okay, so the patient will have a preset on SIMV. The preset rate will be around 6 or maybe 8 sometimes, because now the patient is taking at least 10 or 12 of their own, or even more. So we put them on SIMV. The difference here is, yes, there's a preset tidal volume, preset rate. Between ventilator delivered breaths, the patient can breathe spontaneously with no assistance from the vent. That means, will the vent give the preset tidal volume? No, read again. Between ventilator breaths, the patient can breathe spontaneously with no assistance from the vent on those extra breaths.
They won't get the volume.
They will not get the preset tidal volume. The patient will get whatever they want. If they want 600 tidal volume, knock yourself out. The vent will say, knock yourself out. That's your breath. If they breathe 200 ml, knock yourself out. That's your breath. That's not my breath. All right. But the ventilator, when it's time for the vent to give the breath, it will, of course, give the preset tidal volume, which is 400. Does it make sense? So is this more comfortable?
Yes.
Because where does the patient have more control here? In AC or in SIMV? SIMV is more comfortable. That's why it's called synchronous. Okay, it's more comfortable. However, this will only work if the patient continues to get better. What will happen if a patient is on SIMV and they get worse? What ABG result will show? Acidosis. Okay.
Then you'll have to go back to AC.
Yes, we'll have to go back to AC. Okay, if that happens, which is not really common. Okay, so when we get to SIMV, most patients are on their mend. Okay, because otherwise, if they don't get better, they'll stay on AC indefinitely. So you see those patients on long-term care, those who are on vent units. Do you have vent units, Joy? Yeah, so those patients are on AC, yeah? AC CMV. So those are forever patients, okay? Yeah, they'll be on that mode forever.
So when a patient is straight to vent,
Mhm.
what mode would they be?
AC or CMV. Okay. Again, AC CMV, that's the same thing. Okay, just a different term. Any question on these two? All right, so SIMV can be used for weaning. It can be a main vent mode, meaning that's your main vent mode, but you can also use it to wean. When we use it for weaning though, we keep dropping the preset rate to 4, 2, and then eventually 1. Okay, so meaning patients on their way, and then after that, right, and then we'll extubate them. PSV. This is a purely weaning mode. Okay, it can't be used as a vent mode. It's only for weaning because this is a pressure mode. There's only one setting here, pressure. It only has a preset pressure. No preset rate, no preset tidal volume. So does it give any breaths? Absolutely none. So therefore, how does the patient get the pressure? Patient has to initiate it. Meaning when the patient takes a spontaneous breath, the remember the machine, the vent will sense the sensitivity, right? So when it senses the sensitivity, but it's not set to deliver a tidal volume, it's only set to deliver pressure. So it will just assist the patient with pressure. They reach the sensitivity, let's say negative 1.5. Okay, it will add pressure. That's why it's called pressure support. So it's think of it as, you know, a spotter at the gym. When you require a spotter, like I'm a regular going, you know, I'm a regular who's who's the other one? I'll remember. Okay. You said. So when the spotter hits me, did I initiate it on my own or did he do everything? No, I did it, right? He just assisted me a little bit. Okay, but I did everything else. Yeah. So think of it that way. So in pressure support, that's all the vent is doing. So this is only a weaning mode, meaning the patient's breathing spontaneously. They're having adequate tidal volume. They're just not strong enough. Okay, meaning the pressure that they're taking the breath with isn't, isn't enough to extubate them yet. So we just give them a little bit of pressure support. Okay, so they're not ready quite yet to be extubated, but getting there. So this is only used as a weaning mode. It can't be used unlike SIMV, where SIMV can be used as a main vent mode on a patient who's not that bad. But PSV is only strictly a weaning mode. Those are it. Those are only three modes we have. Any most commonly used modes. Any question on a vent?
So pressure support, can you take, like, if they're not doing well, then they go back to SIMV?
Yeah, same thing. If they get worse, then no, we never go back to SIMV. They always go back to AC. Okay. So we know the settings. Let's go now to a few more which were not mentioned in this chart. Chart 1915 did not mention PEEP. Okay, so let's talk about PEEP. PEEP is always dialed into the ventilator. So PEEP stands for positive because it's not in this chapter. Okay. It's not. Um, okay, here. PEEP. This stands for positive expiratory end pressure. To show you a graph. Okay, here. So this is, look at figure A right here. So what you're looking at, this is zero pressure. This line here, this flat line is zero pressure. Okay. So let's say we are taking a breath. So we go, that's what you see. Okay. This is measuring pressure. So it goes back to zero. So therefore we take a breath. So this is zero pressure, and this is what we call peak inspiratory pressure. And then this is exhalation, meaning the vent just stops blowing air, and then we exhale passively. And then the pressure goes back to zero at the end of exhalation. Now, when we add PEEP, that's no longer the case. Notice that this one does not go to zero. Yeah? So it stays above zero. You notice? Okay. So this is what we call, there is PEEP here. Positive expiratory pressure, meaning the vent maintains a steady push of pressure anywhere between 1, 2, 3, 4, 5, up to 20 centimeters of water pressure. Now, most frequent setting of the PEEP on AC or SIMV is 5 centimeters of water, which means it will stay above slightly here, above zero. Why is this necessary? Now, we don't want, because we're using high FiO2 here, correct? Meaning, is there a risk of absorptive atelectasis? What does that mean? What is atelectasis? Lung collapse. Now, why does the alveoli collapse? Okay, so imagine when you take in a breath right now, it's 21% FiO2, yeah? So we take a breath. So let's say this is your sac. It contains 21% oxygen. So when that 21% enters the bloodstream, what is left in the alveoli? No. There's 21% oxygen. That means 70% nitrogen, yeah? This room air is mostly nitrogen. And there's what? A certain percentage of CO2, and somebody farted earlier. So that's also in the breath, yeah? Okay. So that's the percentage of air. So when the 21% diffuses into the capillaries, are the alveoli empty? No, because there is nitrogen in there, and there's some CO2 and the fart, okay? So therefore, does it collapse? No. So now what happens if your patient's FiO2 on a vent is 60, 80, 90, 100? What happens to the alveoli when all that oxygen enters? Not much, yeah? So can the alveoli collapse? Yes, that's what we call absorptive atelectasis, because you increase the FiO2. Now, when that high FiO2 is absorbed into the capillary, the alveoli will collapse because there's no gas left in there. You diffuse all the gas into the capillary because you increase the FiO2. So now, how will PEEP help? It will keep this air, these air sacs inflated. So the alveoli will stay inflated because you added PEEP. So is PEEP good? Yes, in fact, if you increase the PEEP instead of increasing FiO2, what PEEP does is, because if you think about it, when exactly does gas exchange occur here? Does it occur here, here, or here? Gas exchange. Right here, the gas exchange occurs here, and then as long as it stays high, there's gas exchange here, 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 up to here. So therefore, if you extend that pressure, meaning if you keep the alveoli inflated for longer than usual, are you extending the gas exchange period? Yes. Okay. So PEEP is beneficial as long as it's not that high though, because the higher the PEEP, which is sometimes necessary for a short time, what happens to the heart. So remember, the heart is in the middle. So you have the heart here and your lungs here. So what happens to the heart at this point of the respiratory cycle? During peak inspiratory pressure, when both lungs are at their highest expansion, what happens to the heart?
It's squeezed.
So what happens to venous return? Venous and cardiac output all drop. So therefore, what would happen? But it recovers, right? During this period here, it recovers. The heart re-expands because the lungs let go. However, if you imagine this is only 5. So imagine how high a 10, 15, or even a 20 will be. It'll be over here. So does the heart fully recover, re-expand, if that was the case? Okay, so that's always a consequence. So if your patient ever has a PEEP of higher than 5, watch the blood pressure. Okay, watch the cardiac output because it will suffer from the high PEEP. Okay, so that's a consequence. But if it's 5, we never worry. Okay, 5 is nothing. But when you have anything other than 5, a 10, 15, or especially a 20, so watch your patient's cardiac output because it will suffer. Okay, it will take a hit. Let's go now to your responsibilities. Okay. So here we are. Huh? No, this is just the explanation.
Oh, will you put one of these?
Yeah. Well, just follow the blueprint, whatever's on the blueprint. If the blueprint doesn't mention the mechanical ventilation, no, and that'll be on the final. But I know I have airway in there, yeah?
Yeah. No, for 3?
There's airway there for 3.
No, he's talking about exam 3.
Exam 3 has an airway.
Oh, gas exchange,
Yeah? Yeah, we have airway management then.
Gas exchange,
And there's PE there, yeah? And ARDS. Okay. All right, we still have time, so let's finish this section. So to prevent complications, maintain therapy, here's the position. Head of the bed, always 30 degrees. You can go 45. The problem with 45 is it will cause a higher shear now, or especially if it's over 45, I should say. So safe, just like in head injury or increased ICP, 30 to 45, yeah? But the best again is 30. So make sure your settings are correct. Okay, they're appropriate for the patient. Right? Here. During my time when I went to school, the vents were still capable of being you can disable the alarm, and we can, because it sometimes we're tired of hearing it because it's like the the boy who cried wolf keeps beeping, but there's nothing wrong. The patient's absolutely fine. So we were able to disable the alarm. Now, modern vents, you cannot do that anymore. So you either have to fix the problem or it will never stop beeping. Okay. Of course, there's a reason for that, meaning somebody died, a patient died because of alarm fatigue. Patients, I mean, nurses stopped caring. Okay, it's fine, but then there was something, the story of the boy who cried wolf, yeah? Okay, so same outcome. So now we cannot disable the alarm anymore. You can mute it for 2 minutes, that's it. Then it'll start going off again. So you should really fix it. If you can't fix it, then find somebody who can. Call the respiratory therapist. Okay, so here are our problems. 19-5, the first two here on the blue section here. This one is going to trigger high pressure alarm, or it's also called increase in PIP, peak airway pressure. And then there's also decrease in pressure or loss of volume. So that means this is low pressure alarm. Okay, so these are high pressure alarms. So what can trigger a high pressure alarm? These things will cause it. And the third column is the solution. What do you do? So coughing or obstructed airway will trigger high pressure. What do you do? Suction, blah, blah, blah. All right. So look at each one, and that's your action. This will be a good matrix question on the, or, like a matching, a matching. So I'll put a question like this, and then you indicate the problem, and then what would be your intervention. Okay. So very good matching type question.
At the end question, have you
Yeah.
got it?
Yeah. So this will be matching.
Mm.
Other problems, cardiovascular compromise. Again, remember the PEEP. Okay, so they can cause a drop in your cardiac pressure. Barotrauma. Our lungs are not designed for positive pressure ventilation. We are negative pressure. Okay, so air is supposed to be sucked into the lungs, not pushed under pressure. So when we push it under pressure, of course, that will expose the 100 million alveoli to barotrauma, okay, pressure trauma. Because they will pop open by force instead of passively, right? It's supposed to be passive. They open and close passively. Now you're forcing them. You're forcing air and then forcing them to pop open. Pop, 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 okay. And another thing here is, especially during the post-intubation period. So let's say we intubated Faith at 2:36. So for the next hour, her blood pressure will drop. Why is that? Because a moment ago, before 2:36, she was breathing fine. Okay, she was fine. And then she suddenly suffered a PE, for instance. Okay, we had to intubate her. So what happened to the intrathoracic pressure? Increased. And then what happened to the venous return? Decreased. Cardiac output decreased. And then remember, when she was in distress prior to the intubation, what was her catecholamine level? Her fight or flight hormones. They were high, right? But then here we did rapid sequence intubation in 30 seconds, right? So the whole thing changed in 30 seconds. So suddenly she had airway in 30 seconds, and then she was connected to a ventilator a couple minutes later. So what happened to all those changes? Did they occur gradually? No, those increases in pressures, the loss of catecholamine, did they occur slowly? They were rapidly. They happened like this. So therefore, can the body adjust to all that changes? No. So always expect blood pressure to be low shortly after intubation. So we call that post-intubation hypotension. So the patient always will require levofed. Remember norepinephrine we talked about in shock? Okay, so the patient will require norepinephrine. So prepare for that. This is your patient. Make sure you have enough lines, because norepinephrine drip will be on its own. Okay, you can't give anything else to that line. So she will require one line for the vasopressor, and then she also requires IV fluids, possibly antibiotics, or whatever was her other problems. Okay, so she'll require several IV medications. Remember, she also needs to be sedated, yeah? So you have your propofol drip as well. Okay, so again, she needs plenty of lines. Okay, that's why most people in the ICU have a central line. Okay, that with multiple lumens, so that we can infuse several medications, because not all of them are compatible. Pulmonary infection, this would be the ventilator-associated pneumonia. We'll have the bundle here, because remember there was a surviving sepsis bundle. Okay, there's also a bundle for ventilator-associated pneumonia. So if Faith or Meijin stays on the ventilator for 48 hours or longer, they start the risk for aspiration pneumonia, or no, not aspiration, ventilator-associated pneumonia begins. Okay, so she could develop VAP, or ventilator-associated pneumonia, on her third day. Okay, same thing for Meijin. We have other therapies here, especially if the patient has ARDS. So we will put the patient in prone position. We can do that with specialty beds. And we have beds that literally turn 360 degrees. So the patient Faith can be strapped, okay, from head, chest, and her legs, and her feet will be strapped to the bed, and the bed will turn. Okay, so she can be prone to drain her secretions. Okay, so that will help drain, her lungs. Yes, we did that because remember, COVID patients died from what? From sepsis, yeah, because they had pneumonia and they developed sepsis. So they had ARDS, they had DIC. So that's what killed those patients. Okay. So yes, these patients will include, today we don't really have those anymore. I mean, yeah, people are surviving COVID now. Okay. They die from other things now. We still have a lot of sepsis, but not from COVID anymore. Okay, so for our, I'm just looking for the VAP bundle. VAP, yeah, ventilator associated pneumonia. That's in extubation. That's home.
Oh, wow. I didn't see.
Not yet, almost. Okay, here. Page 533. Okay, so preventing ventilator-associated pneumonia. There are 5 elements. Head of the bed, again, 30 to 45. Daily sedation vacations. This is, we simply wake the patient up, meaning we stop the sedation infusion a couple hours at a time to see how they handle. Are they handling fine when they're awake? Okay, are they breathing okay? Peptic ulcer prophylaxis. Now, this is part of the VAP bundle because technically, if they aspirate and the acids that they aspirate, the gastric secretions that they aspirate are very acidic because you didn't give any PPIs or H2 receptor blockers. So what will happen to the lungs if you aspirate, a pH gastric secretions of 3, 4? So what will happen to the lungs? Is that direct lung injury? Is that acute lung injury? Can that cause ARDS? Okay, so therefore it's part of the bundle. Okay, so uh, um, pressure ulcer prophylaxis is part of the bundle. What are those 2 drugs we use again? H2 receptor blockers and PPIs. Okay. No, sorry. Okay. DVT precaution is included, okay, in the VAP bundle. And then the oral care, very important, because if they do, can we absolutely prevent aspiration? No, they aspirate all the time. Okay. Yeah, we suction. However, again, we can't prevent aspiration. There will be aspiration. Okay. So therefore, if the secretions that go down there are clean though, is that still gonna cause pneumonia? No. Okay, so therefore, is mouth care part of the bundle? Yes. How often do we do it again? At least every 2 hours. You turn the patient every 2 hours. You also do mouth care every 2 hours. Right? Yeah, I know, but in practice, I mean, what do you want? Do you brush your teeth once a day? I mean, common sense. So if we brush our teeth 3 times a day, how much more for these patients who cannot swallow, okay, cannot close their mouth because of the of the plastic airway. So do we do the mouth care more often? Yes, every 2 hours. So that, because again, they can't close their mouth. So everything in the air is going into that mouth. Okay, so there's all sorts of critters there. There's vermin going in and out of the mouth. So clean it. Let's say you're the patient. Kirko, do you want me to do mouth care every 2 hours or just once a day?
Every 2 hours. 4 hours.
Okay, very good. You're welcome. All right. Okay, we already talked about PE. Okay, that's it.
This is the last lecture, right, Professor?